because July is Fibroid Awareness Month, so we are at the end of the month today, just talking about this topic that is really important for Black women's health. So just our overall agenda for today will be about an hour and a half of our community conversation. We'll start with intros, and Michelle and I will describe a little bit of what genetic counselors are and what we do. We'll just go over some community agreements before we start sharing experiences and sharing knowledge. Gabrielle will introduce Black Women for Wellness's mission and talk a little bit about reproductive justice. Then we will fold into Fibroids 101 and end with some discussion questions.
Hi everyone. My name is Gabrielle Brown. I am the Maternal and Infant Health Program Manager here at Black Women for Wellness. Very grateful to be in space and have the opportunity to connect with all of you.
And my name is Helen Kim. I'm a genetic counselor and currently in the genetics education space with a group called Personal Genetics Education and Dialogue. My clinical background is in cancer genetics in a community hospital based in Los Angeles. And I'm also part of a group called Alliance for Genomic Justice, which Michelle will talk a little bit about later after me.
Hi, I'm Michelle Takemoto. I'm also a genetic counselor and I'm based in Hawaii. So the Alliance for Genomic Justice works on advancing health equity and workforce diversity in the genetic and genomic healthcare space. So having to do with genetic counseling and genetic testing.
And well, before we jump into genetic counselors, I just wanted to point out that I'm not a treating physician or a gynecologist myself. I am a healthcare professional, though, and a part of what genetic counselors do very often is provide accessible, boiled down, important information for our patients when the medical information is very complex. So just explaining what we typically do. We wear a lot of different hats depending on what needs to be met. But a basic part of what we do is a role of a teacher and a counselor. So providing information to our patients about genetics, how certain conditions might be inherited in your family. And we also discuss benefits, risks, limitations of genetic testing and what that could provide answers for you. When we get the results from the testing back, there is somebody who needs to interpret what this means to your case, and this is often what we do. And we help patients make decisions whether genetic testing is right for you and how to use those results to help you and your family obtain the best care as possible. A big part of what we do is provide psychosocial support to patients and families, but also we train other healthcare providers on genetics and communities, including patient communities as well. One thing I just like to mention is that seeing a genetic counselor doesn't necessarily mean that you have to do a genetic test. It's part of the process of genetic counseling. And so for any given day, depending on the cases and the patients that the counselor is seeing, they could play any of these roles. They could be a scientist, a detective. We are looking at family history to see if we can parse out if any part of a condition is inherited. So we're doing a lot of detective work. Also being an information provider and a teacher to our patients, translating very complex genetic information into something understandable. And we advocate for our patients as well. Okay. You can find us working in a variety of settings. So here are some specialty areas that are more common in genetics, but you can find us in university, hospitals, laboratories, nonprofits like myself, or in the government like the NIH. So we work in lots of different spaces. Before we jump in and discuss personal stories, we would like to just establish some community agreements. These are some agreements that we have come up with, but please let us know if there are others you would like to see. So I'm speaking from our own experience, listening to understand, not to respond, owning the impact of our words. And every person is not obligated to share. If they are willing to, we are invited to share, but there is no obligation. And we will share the floor and take turns passing the mic and sharing our experiences. Before I jump into the didactic portion, I also wanted to point out that I will be using the word women a lot in this talk, but fibroids can affect anybody who was born and assigned female at birth or currently has a uterus. So just a note on inclusivity, women are typically used in talks like this because most of the research has been done on women, but in order to include everybody who has a uterus, fibroids can really affect anyone.
Great, thanks, Helen. And so now I want to provide a bit of background on Black Women for Wellness. And so we are a nonprofit reproductive justice California-based organization. We have a location based here in Leimert Park in Los Angeles, as well as Northern California in Stockton. But we are committed to the health and well-being of Black women and girls through health education, empowerment, and advocacy. And so as the maternal and infant health program manager here at Black Women for Wellness, I lead a program where I use and plan programming in the community as well as policy to bring attention to the disproportionate rates of Black maternal and infant mortality. And so a lot of that work is reproductive justice based and focused. Next slide, please. And so I really want to start off by providing this foundation and defining reproductive justice. And so women of color, particularly Black women, began to critique the mainstream reproductive rights movement in the 1970s and the 1980s for its failure to address the unique reproductive issues faced by marginalized communities. And so the concept of reproductive justice was first articulated in Chicago in 1994 by a group of Black women activists called Women of African Descent for Reproductive Justice. And so these women recognized that the women's rights movement at the time, led by and representing middle-class and wealthy white women, could not defend the needs of women of color and other marginalized women and trans people. And so thus, RJ was born. And so RJ is a human rights framework and social justice movement that goes beyond the concept of reproductive rights to address a broader set of issues related to reproductive health, autonomy, and equity. RJ emphasizes the right of all individuals to make informed and autonomous decisions about their reproductive lives and to have access to the resources and support needed to realize those decisions. And so ultimately, the RJ framework recognizes that reproductive rights cannot be fully realized without addressing intersecting systems of oppression such as race, class, gender, and sexuality. Next slide, please. And so now I am going to do a breakdown of the 4 tenets of reproductive justice. And so I will start with the right to bodily autonomy, with free from all forms of reproductive oppression, which is a fundamental principle of reproductive justice. It asserts that individuals have the inherent right to make decisions about their own bodies and reproductive health without interference, coercion, or judgment from others or the government. So that includes access to abortion, contraception, medical decision-making, consent, gender-affirming care, freedom from forced sterilization, privacy, and protection from gender-based violence. Next is the right to have children. So every person has the right to choose whether or not to have children and when to have them. This includes the right to access comprehensive and affordable reproductive healthcare services, including contraception, and fertility treatments to support their reproductive choices. Next is the right to not have children. So just as individuals have the right to choose to have children, they also have the right to choose not to have children. And so this looks like access to safe and legal abortion services, as well as education about reproductive options and family planning, which is a fundamental aspect of RJ. And lastly, the right to parent in safe and supportive environments. So people who choose to become parents have the right to do so in an environment that is safe, supportive, and free from discrimination and violence. This includes access to adequate health care during pregnancy and childbirth, as well as support for raising children in healthy and nurturing conditions. And so these 4 tenets of reproductive justice highlight the importance of ensuring that all individuals and communities have the freedom and resources to make decisions about their reproductive health and family planning that are not limited by social, economic, or political factors. It is a holistic approach that aims to address the intersectionality of issues related to reproductive rights and social justice. Next slide, please. And so, with it being Fibroids Awareness Month, it's critical that we make the connection between reproductive justice and fibroids in Black women. And so, as I discussed, reproductive justice is a critical framework that goes beyond the traditional focus on reproductive rights to address the broader social, economic, and political inequalities that affect an individual's ability to have and raise children. And so this concept is particularly relevant when examining the health disparities by Black women, including the high prevalence and severe impact of uterine fibroids. Understanding the intersection of reproductive justice and fibroids is essential to advocating for equitable health care and improving health outcomes for Black women. And so some of the key connections we'll be making today are around 1, health disparities and access to care. So Black women often face barriers to timely and accurate diagnosis of fibroids due to systemic biases and inadequate access to healthcare. It is essential to ensure equitable access to a full range of treatment options, as well as culturally competent care. Next is economic inequality. So the economic burden of fibroid treatment can be significant, exacerbating existing economic disparities. Also, severe symptoms can lead to missed work, job instability, and further economic hardship for Black women who have the highest prevalence of fibroids. Next is educational disparities and awareness. So increasing awareness and education about fibroids within Black communities is crucial for early detection and treatment, which is why spaces like this are so valuable. And so our goal with today's workshop is to empower you with, workshop is to empower you all with knowledge about your health and treatment options and enhance your ability to make informed decisions while seeking care. Next, we will touch on environmental and social stressors. So chronic stress from racism, discrimination, and socioeconomic challenges, also known as weathering, can contribute to the development and severity of fibroids. And so building strong community support networks and advocating for policy changes to reduce environmental toxins is vital. And lastly, historical and systemic racism. So addressing the historical mistrust of the medical system among Black women due to past abuses and ongoing discrimination is crucial. Ensuring the representation of Black women in medical research related to fibroids and advocating for systemic policy changes are key steps towards equity. By examining the issue of uterine fibroids through the lens of reproductive justice, we can better understand the complex interplay of factors that contribute to health disparities faced by Black women. This approach highlights the need for systemic changes to ensure that all women have the right and ability to make informed decisions about their reproductive health, free from discrimination or coercion. Advocating for reproductive justice in the context of fibroids is a critical step towards achieving health equity for Black women. And now I will pass it on to my colleague, Helen.
Thank you, Gabrielle, for a wonderful overview of what's to come in the next slides. Before we jump in, I wanted to bring up Jessica Petway, who passed away earlier this year in March 2024, which sent rippling, shocking effects through many, many communities. Certain studies have already looked at how much women and minorities are likely to experience a misdiagnosis. That's about 30%, according to a study this year in 2024. But what happened with Jessica was a beauty influencer, was she was misdiagnosed with fibroids while she was experiencing profound pain and a lot of bleeding. But in reality, she wasn't worked up completely and she did not receive standard of care. And what she had was cervical cancer. Unfortunately, she passed away early due to this misdiagnosis. Lots of what has been reported in the literature, and as we already know, extreme bleeding tends to be dismissed as normal and common, especially if we have family members who also experience symptoms similar. It's easy to dismiss them as, oh, they'll go away. This has been normal for my family. But we will provide you with some guidance in the next slides, what things to look out for, what things to be concerned, and how to bring up some of these concerns to your healthcare provider. I want to mention that all of the didactic material are put into a written resource that will be sent to you at the end of this talk. So please don't feel pressured to have to write everything down. You can just listen and that should be okay. So starting with some background about fibroids, these are extremely common. They're technically tumors, but they're overwhelmingly non-cancerous. So they are non-cancerous tumors that develop and form within the uterine wall muscles. Anybody who has started their periods or in a reproductive age can be affected by fibroids, but most commonly people between age 30 to 50 years are affected. Both the estrogen and progesterone, both the what we call women's hormones, play a role in developing these fibroids. So after menopause, they start to tend to shrink. That's possible. When we look at the prevalence of fibroids in Black women, it affects up to 80%. So that's about 8 in 10 Black women up to age 50, compared to about 70% of white women. It's common for women to never know that they have fibroids if they never experienced symptoms or never been worked up. That's certainly possible. But what we do know is that Black women tend to experience multiple fibroids and more severe symptoms that can lead to hospitalization. And the fibroids can be a single tumor, or they could be in a cluster growing many together and big in size. Just to compare how large the size can get, they can be a little bit 2 centimeters long, like a little peas, or it can be larger than a grapefruit, or it can also make a person look pregnant if the fibroid is that much big. Some folks face challenges with infertility and pregnancy complications, and we'll talk about when that happens. If the location of the fibroids happens inside the cavity, then there could be some complications to it, but it depends on each case. And statistically, we say about 5 to 10%, that's 5 in 100 women, 10 in 100 women, 1 in 10 women have infertility that are due to fibroids. Now, to talk about the symptoms, we can easily identify 3 categories of symptoms of fibroids, which are bulk, bleeding, and pain. Bulk, meaning you start to feel bloated, there's pressure and pain that starts to make your belly look bigger. So pelvic pain, back pain, abdominal bloating, anemia, fatigue, that would count as a bulk symptom. Bleeding that results in a heavy bleeding that you soak through more than 1 or 2 tampons or pads over 1 or 2 hours, or pain that lasts, or bleeding that lasts over 5 days, can be considered excessive. You can also, some folks see that there's a big clots in the blood that they are passing. And frequent urination can be a phenomenon, especially if the fibroids are growing big enough that are now pushing against certain organs in your body. And then pain, of course, pain that doesn't subside with using typical over-the-counter pain medications, so Advil, Motrin, Aleve, the pain that can't be tapered by some of these over-the-counter medications. Then we start to think maybe we should go see a doctor and talk about these symptoms. So I wanted to talk about the different fibroids and where they can develop, and the different locations within the uterus. So you see the vaginal canal here and the cervix. This would be the uterus, and then your fallopian tubes where your eggs come out of, on both sides. And so this cavity inside is where an embryo would implant and grow in. So thinking about, the bulk pain and bleeding symptoms, we can almost start to predict where the fibroids can be based on those symptoms too. So 3 different categories of fibroid growth is in the cavity, or it's in the muscular area here, or in the outer surface. So for example, what we call a submucosal fibroid, these are tumors that are starting to grow inside the uterine muscle wall. They start to push into the cavity and start to cause heavy bleeding. If you have fibroids inside the cavity, that could distort and cause infertility or increased risk of miscarriage that could be possible with the submucosal fibroid that from the wall. Whereas compared to an intramural fibroid, which is growing inside within the muscle wall, this can cause all 3 categories of symptoms. So bulk, bleeding, pain. It can start to compress or distort the cavity or the fallopian tubes. When this organ is in your pelvic area, they're all kind of smushed together. So this can start to push on this, or even the ureter where you pee, that can be affected too. Of course, if it starts to go into the cavity again, this will affect maybe some increased risk of infertility or miscarriage. But when they're very small, they can be very hard to locate surgically. So most fibroids will not be found by just a routine pelvic exam. Typically we have to do some imaging, so I'll talk about that a little bit more. But this category where it starts to grow on the outer wall of the uterus is called a subserosal fibroid. And it can cause pain or bulk symptoms, but it doesn't cause excessive bleeding. And it doesn't cause fertility problems as long as it's not getting into contact with the endometrium. Then the rare type of fibroids that can develop sort of outside, like a thin stalk that develops outside the uterus, is called pedunculated or pedunculated subserosal fibroid. Thank you for being patient with my words. Michelle, did you want to take? Yes, I will let Michelle take over.
So, like many other conditions, the impact of fibroids on the lives of Black women is more severe in many aspects than it is for white women. Black women are likely to have more fibroids, larger fibroids, and to have them develop from an earlier age than white women. As you can see here, there are many factors that may contribute to fibroids that are likely magnified by racism and the enslavement of our ancestors. Heart disease and high blood pressure, pollution in Black neighborhoods because of segregation, hair products like relaxers that we're encouraged to use because of racism in the workplace and the pressure of white beauty standards, vitamin D deficiencies because melanated skin is not adapted to northern climates where there's less sun exposure, unhealthy diets because there may be less access to fresh produce in our neighborhoods. The list of likely factors goes on and on. Next slide. Fibroids do appear to run in families. So if your mother and other family members have a known history of fibroids, you are more likely to have them too. This may or may not have to do with genetics and heredity, but not much is understood so far about genetic factors because there isn't enough diversity in the world of scientific research. And so very few scientists are exploring conditions that impact our communities more than others. So it could appear to run in families because of all the environmental and social impacts on our communities. If it eventually turns out that there are genetic contributions to fibroids in Black women, this doesn't mean that these are genetic flaws. Environmental factors like stress, pollution, diet, and all of those things are known to raise the risk of all sorts of health problems by interacting with genetics. And so this is likely to be the case with fibroids. Generally speaking, anything that we're able to do to maintain good health may help with prevention of fibroids too. If you're experiencing symptoms that you know are not normal for you, then hopefully you'll be able to advocate for yourself, or you have people around you who can also help advocate for you to get appropriate care. Next slide. The assumption that Black women have a higher pain tolerance or that our symptoms are all in our heads are rooted both, of course, in racism and sexism. And as we've mentioned, Black women are more often offered treatments for fibroids that are more invasive and have longer recovery times, and they're more likely to interfere with fertility. It's important to be aware of your options and ask questions as much as possible, share information with others. It may be difficult in the setting of a doctor's appointment to ask questions if they don't appear to be listening. And so again, that's why it's so important for us to share information with our friends and family.
You're muted, Helen.
I'm so sorry. I am not muted anymore. So thank you, Michelle, for covering that. And I will now talk about how fibroids are diagnosed, what treatment options exist for you. Fibroids are, as I mentioned earlier, if they are big enough, your OB-GYN can feel them through a manual pelvic exam, then perhaps they can find it. But by far and large, they won't be able to just manually detect all of the fibroids that they could be missing, especially the small ones that are missed by pelvic exam. So if your provider is told, hey, I might have some fibroids, can you work me up for this? Then typically what they will order is a pelvic ultrasound. So that handheld device that gets pressed on your abdomen when they look at your baby when you're pregnant, they can do it transabdominally or transvaginally, which is taking a probe and looking inside of the vagina. So I have been through this before, transvaginal ultrasound. Typically, they will hand you the handheld ultrasound device and tell you to move it up, move it down, to the left and to the right. If you have a male technician, there should be a female technician in the room with you. If you also feel like they are trying to redirect and take images and you're not comfortable with that, please speak up. you should be in charge of your body. Another method they may use for imaging is pelvic MRI. So putting you through a coil of magnetic resonance to try to image that area and get a better resolution. And a third way they could try to look at inside of the uterus is inserting a small camera up into the uterus. So this is called a hysteroscope. It's like a camera, and they'll try to see if they can look at and locate all of the different fibroids that exist. And then lastly, the doctor may order a blood draw to check if you've been bleeding a ton and if you currently have anemia, and that needs to be treated.
May I ask a quick question?
Sure.
What's the difference between a transvaginal and a transabdominal?
Yes, great question. So the transabdominal ultrasound will be done externally on your body, kind of like when you're going to like your first trimester fetus anatomy appointment and they're looking for the baby inside your uterus. It will be the same area and they will look at the same area. The transvaginal ultrasound is a bit invasive. So the probe, instead of it being externally outside your body, the probe is inserted into your vagina. This is where, after the initial insertion, they will have you actually hold the probe itself, and they'll tell you, move it left, right, up, and down, and start to take images on their computer. Does that answer your question?
Yes, thank you.
Thank you. Okay, so you've tried Aleve, you've tried Advil, pain's not going away. There has to be a better way to intervene. So I want to talk about the treatment options that exist. Most often you will be offered at least a couple of different approaches that could fit your case in the best way. But first, not talking about the surgical aspects, there are medications to control excessive bleeding and excessive pain. Your doctor may give you hormonal birth controls or IUDs if you don't have a fibroid growing in the uterus already, to try to prevent the growth of fibroids, which are due to estrogen. Tranexamic acid, these are pills, so they also look like the pills that you get from your doctor for birth control. They control bleeding by controlling the breakdown of blood clots. So it's not used every single day like a birth control pill. If you just want to be able to take something that tapers off the bleeding incidentally, just when it happens, this would be a great way, tranexamic acid. And then
So yeah, he let him know.
any questions? Okay. And then a second option is what's called a gonadotropin releasing hormone pills or injections. And these are meant to suppress your ovaries from producing estrogen. It's supposed to lighten your period, perhaps shrink the fibroids, but the duration of usage is limited with this method. So they would only prescribe you for about 1 or 2 years. Sometimes you're prescribed these pills right before surgery to try to shrink the fibroids as much as they can. Or if you're just in the middle bridge going into menopause, they may give you some of this to try to taper the symptoms of menopause. Now, going into surgical approaches, again, ideally you're being offered multiple treatment options that take into consideration your age, your symptoms, your lifestyle, how much time you can take off of work, how much insurance covers the method and the procedure, as well as your future plans for pregnancy and your relationship with your body, your spirituality, as well as other medical conditions that you may be managing at the same time. One of these minimally invasive surgical ways is called a uterine fibroid embolization, and can be abbreviated UFE or UAE as for artery. This method is not done by your gynecologist, but a specialty called interventional radiologist. So what they'll do is they'll either choose your vein on your wrist or your groin and find a vein to insert a catheter through and try to block the blood vessels that are feeding the fibroids and making them grow bigger. When we cut this blood supply, on average, fibroids shrink about by half of its size, original size. But what I wanted to mention about the UFE method is that it's not recommended for preserving fertility. They do think that when the blood flow is blocked into that area, it can affect embryo implantation and growth. So it's contraindicated for preserving fertility, but it can be done quickly in the office. You only need a couple hours of recovery, then you can go home after the procedure. If you don't have an interventional radiologist in mind, you can also ask your gynecologist to make a referral to them so that you can discuss further, what procedure will be taking place. Again, moving into two different minimally invasive procedure. The second one is called the radiofrequency fibroid ablation, or an RFA. And essentially the idea is that they place you under anesthesia and the needle-like probes are inserted into the fibroid either through the abdomen or through the vagina. And then they start delivering these radiofrequency heat to try to destroy the fibroid. Laparoscopy, you may have heard of this word, is when they make small little incisions along your bikini line, and they start to insert the needle probes directly that way, or it can be done through hysteroscope, through the vagina, through the cervix, and through the uterus. What we know about fertility and RFA is that there's no consensus quite yet about whether RFA is a recommended method for preserving fertility. So they're still doing research to determine that. And then the third minimally invasive methodology is called focused ultrasound. And this method is available in limited sites across the United States. And I'll talk about that in the next slide. But they use MRI guidance. So they try to image your uterus and try to locate where the fibroids are. Then they start to send focused heat through the ultrasound to destroy the fibroids, right? So this method is using radio frequency. Focused ultrasound is using ultrasound, the heat that comes from the ultrasound. This is also performed by an interventional radiologist. And the effect on fertility, there's actually the review that was done this year cited that there's a higher rate of spontaneous pregnancy and full-term delivery with this method. But compared to women who go through a surgery to surgically cut out and remove, which is called myomectomy, I will explain that in a couple of slides, they could have higher rates of miscarriage. So all of these methods, there's pros and cons, and of course, things that we need to weigh according to the particular case of the patient, depending on how big the fibroid is, how many there are, and if they're invading into the cavity. But this is the newest and sort of the most advanced technology that is out right now. Which brings me to the next point, is that these focused ultrasound method, there's been a very slow adoption to it due to insurance policies not having decided yet whether this is an economically feasible way for them to cover this method. And so currently there's about 300 treatment sites across the United States. If you go to large university medical centers like UCLA, Cedars-Sinai, USC, you could probably find a interventional radiologist who has focused ultrasound. Whether that is fully covered, though, is a different challenge. So we're really hoping this White House initiative on women's health research continues, and that we start to provide insurers with the evidence that this is actually a really great way and an option to offer to all women. Spontaneous pregnancy. Just what I meant by that is that you are able to get pregnant and that you're not experiencing any infertility symptoms like recurrent miscarriage, things like that. Does that help clarify? The other gaps with Black patients in particular getting offered different surgery options and them really being offered hysterectomy as the only option in many cases. There was a study that they ran to see, well, what are they being offered and what are they undergoing? And they looked at white women, Black women, and Hispanic women. And about 81% of white women were undergoing minimally invasive surgery, the 3 methods that I just talked about, versus about only half. So you can already see there's a massive disparity and, wondering, what are the conversations like in that clinic room when the options are being presented in front of the patients. Yes, these treatments are available in Los Angeles. Yes, so I am not sure about Kaiser, but maybe I could ask Erin after because she works at Kaiser. But it depends on also your surgeon's training and your surgeons, whether some folks like to do the surgery on their own, or some folks like to use robotic surgery for different reasons. So it also depends on your doctor's specialty and training. But now I will talk about the surgery that is most often done to remove fibroids and preserve fertility at the same time. So currently, most likely if you go see a doctor and talk about, well, I want to become pregnant in the future and I don't want to risk any possibility of, my uterus not being able to hold an embryo, then this would be offered to you as the gold standard, but it does depend on, again, the number and different sizes of fibroids you may have, and it can be done through the vagina using a hysteroscope that goes all the way up to the uterus. This results in a very quick recovery, and there's no need for incisions or puncturing on the skin. To do it in a minimally invasive way, we would use laparoscopy again, which is that small little incisions on your groin, on your bikini line. And this is done under general anesthesia. So the smaller the incisions are, the faster you will recover and the lower risk of complications if you are a candidate for myomectomy. And then if you have fibroids that are really big and need to be intervened through the abdomen, this involves traditional open surgery that involves a C-section-like cut across your abdomen. The surgery itself with this big cut lasts faster, but there's a longer recovery time. So there's pros and cons there. With larger incisions, you also risk complications later. And you may be told by your doctor after that in the future, when you're delivering a baby, to have a C-section instead of doing a natural delivery, because there has been a cut already made and there is a little bit of a risk for uterine rupture in your future pregnancies. And depending on where that fibroid lives, if they happen to cut into the uterine wall, that could affect fertility as well. But it depends on what fibroids look like for you individually and what it seems to look like on the MRI and ultrasound images. But you will be counseled for this. And if you're not being told and not being educated, then it's time to seek second or third opinions. Getting one treatment option offered only isn't enough. You should be able to explore different options in your discussion with your physician. And then lastly, I will pass this on to you, Michelle. or I can talk about the hysterectomy part. Yeah. Okay. So the hysterectomy is the most radical surgery. It's a completely removing your uterus and your fallopian tubes. And this will ensure your fibroids will not grow again. The only limitation about the other methods that I covered so far is that fibroids can technically come back. So this method ensures that fibroids don't return, especially if they have many and large fibroids. Doctors may tell them like this might be your best option, but no one should undergo hysterectomy if they don't feel comfortable with it. There are other ways to address this problem. So if they're not listening to you, if they're not listening to your needs, and you can feel that, you can, when you're in the clinic room, you know when your provider is listening to you or not, then you are entitled to seek other opinions. And then what happens with the hysterectomy though, especially if you are premenopausal and you get rid of the uterus and fallopian tubes, it kicks you right into early menopause. So you then start experiencing menopause symptoms like hot flashes, night sweats. And so this is where I wanted Michelle to chime in.
So yes, early menopause is no fun. So yeah, hot flashes, night sweats, depression and mood swings, those can be a part of menopause. There can be brain fog that comes with it. Unfortunately, research has found that that doesn't necessarily last forever, but there are also support groups for Black women specifically around issues of menopause. So for folks who end up going down this road, there are resources. Next slide. So anything that supports your mental and spiritual health also supports your physical health. There is no separation between mind, body, and spirit. And so relying on networks of relationships and community are important aspects of a patient's journey with fibroids and the treatment for fibroids. So even if you don't feel comfortable bringing these things up with your doctor, or if you feel like your doctor is being dismissive of your faith, that does not mean they're not important. They absolutely are. And religious services, prayer, meditation, yoga, massage, anything that makes you feel connected, grounded, supported, less stressed out. All of these things have a role to play in your coping and your healing. It can be hard for us to feel okay about being vulnerable and letting other people take care of us, but having to tough things out through pain and excessive bleeding is not okay. The strong Black woman stereotype shouldn't mean that suffering is acceptable. It can be a challenge at work and at home to find the support that you need. So there are support groups out there that are specifically for Black women with fibroids, and we'll be sharing more information about that. Therapy and counseling, especially with Black therapists, should be an option, although it may be hard to find Black therapists because there may be waiting lists. Fortunately, therapy has become more common these days, and hopefully you can find someone that you're comfortable with by asking around or searching online. Next slide. These are some overall wellness tips that may help with preventing fibroids and coping with them if you have them. So leafy greens, cruciferous vegetables, so things like broccoli and cauliflower and fruit are all great additions to your diet. Hopefully they're available in your neighborhoods. Vitamin D supplements can also be a good idea, as well as reducing alcohol, caffeine, and red meat. Not as much fun. Any exercise, both vigorous exercise and relaxing exercises, are good for your health. Acupuncture can also be helpful with fibroids if you're comfortable with it. One important note is to talk with the girls and young women in your family about fibroids so that they can start learning to be aware of their own bodies. So they know what is normal for them and what is not. So if they start having excessive pain, excessive bleeding, that they feel comfortable coming to you or someone in the family, and letting their medical providers know. The White Dress Project and the Fibroid Foundation have support groups that are specifically for Black women with fibroids.
Okay, so just wanted to start talking a little bit about how to advocate for yourself in a healthcare clinical setting. Clinical setting can be, stressful and overwhelming, especially if your provider is not spending a ton of time with you to talk about all of the different aspects of what you're experiencing with fibroids. But just a good rule of thumb, finding a provider who looks like you can sort of minimize confusion, communication, cultural different errors that could happen in a clinic room. And it helps to talk to your gynecologist early about how your menstruation patterns typically look like. So keeping a period diary in sort of like a written form instead of using apps, because they can report to law enforcement, unfortunately. So folks who live in red states to try to avoid using these period apps, but just having a written period diary, keeping track of how much you're bleeding, how much pain you're experiencing, what other symptoms are coming up for you, like fatigue and pain during sex. All of those things can be kept track and then reported to your doctor. Heavy bleeding where you're soaking through and you're bleeding through your clothes are not normal symptoms, and they should be worked up and looked at by a clinician. And I find it sometimes helpful to write your questions down in a list and then bring them with you to the appointment. If you have family or friends who can show up to the appointment with you, that's very helpful. But if they can't, maybe being able to phone them in the middle of a clinic, just so you have another person who's listening to your conversation with your physician, can be supportive and helpful. The last thing I wanted to mention with the healthcare advocacy is that there are other conditions that may fit the typical symptoms of fibroids, like excessive bleeding and pain. So it's important to ask your doctor, what are some other conditions that you are thinking of that fits my symptom profile? And again, thinking about what Jessica Petway went through, not being worked up for all the conditions that she should have. It's important to tell your doctor, hey, I want to know if you can look for other conditions and just make sure this is in fact fibroids and not something else. And you should be provided all the information. So if you're not being explained, if you're being dismissed, you don't have to stick with that physician. They should give you expectations about after surgery, and also establish a plan with your doctor about who to reach out to get prescription medication. All of those can be helpful before you undergo surgery, if that's something you're undergoing to treat your fibroids. Oh, another question, herbs or natural treatments. So what I have seen in the literature is there's not a really conclusive evidence for using like herbal and different supplements that have been reported. The only thing that has been seen to reduce fibroid occurrence is just vitamin D supplementation. But of course, oh, sorry, just looking at the next question. But of course, if you have naturopathic sort of treatments or diet or providers who can help you holistically like manage, other parts of your life too that are causing a lot of extra stress, that helps you keep a healthy diet, then, that's certainly we support that. Whatever helps you on your journey to your wellness, we support it. According to medical literature, though, there hasn't been a straightforward evidence that we should be taking certain supplements. Oh, yes, and the acupuncture question came up earlier. The acupuncture itself cannot treat fibroids, but it can help with pain management. Sometimes some women find a lot of benefit, as well as what Michelle talked about with massages. You know, everything is sort of a holistic picture. Latoya asked, how can you know whether it is fibroids or cancer? So most of the time, we don't exactly know until the physician is able to go in and take a sample and treat the fibroids. So typically when uterine cancer is discovered is when doctors go in to do the surgery on the fibroid itself, and then they find at that time that, okay, this is actually cancer. So until your fibroids are looked at, we don't know. So that's why it's important to bring up to your doctor, you know, please look whether this is cancerous or not. Fibroids itself, 99% of the time is not cancerous, but with uterine cancer in Black women, there's a higher incidence of that. So we do need to look out for uterine cancer as well. A second question came up, can you get fibroids post-menopause? Do hormone feed fibroids? Okay, great question. Oh, I didn't add it here. Let me just put it up. So post-menopause, because your estrogen, progesterone falls, your fibroids actually start to shrink. So the hormones, if you're talking about like hormones from birth control pills, no, they don't actually feed fibroids, but they actually, what happens when you take hormonal birth control is that it shuts down your ovaries and uterus from producing its own progesterone and estrogen that makes it grow, but it provides an external source of estrogen that can help the body start to regulate more. So that's sort of what we mean by hormone birth control pills. The other aspect of the hormone that you could be asking is with hormone replacement therapy with perimenopausal symptoms. They have seen, you know, there has been some studies looking at whether hormones for menopause are safe, and they did find that unless you've had breast cancer already, uterine cancer already, then a lot of women are candidates for hormone replacement therapy that can decrease their risk of postmenopausal conditions like osteoporosis, bone loss, and heart disease and dementia. I hope that answered your question, and I can answer it again if that didn't make sense. But let me go back to where we were. Okay, so maybe we could stop the recording perhaps here. Yeah. But we wanted some audience participation.